everybody. Welcome to Be Empowered, the podcast. This is a podcast where we dive into the realities of healthcare and entrepreneurship. We offer our opinion unfiltered and apologetic, and always with a dose of empowerment. We're here to amplify voices, yours and ours, challenge the status quo, and explore what it truly means to thrive. So let's get into it. I'm Dr. Santoshi Bulakota.
And I'm Dr. Shala Mata.
And today we're going to be talking about physician contracts and what to watch out for. So, this is going to be a really interesting episode, I think, and hopefully a very useful one because even though Shala and I are not contract lawyers, we've seen enough contracts at this point that I think we can give some tips on what to watch out for and what not to watch out for. I think the reality is when a lot of us come out of training, none of this is like taught to us. Like no one talks to us about this is how you should evaluate your contract. Um, Moreover, I don't think a lot of us are getting contract attorneys to review our contracts, which we'll talk about why that's important. But before we start, Shala, tell me, with your very first attending contract, did you have a lawyer review it, or how did that process go before you signed?
Unfortunately, I didn't. I didn't think I needed it, and I hear this from a lot of graduates, new graduates, that it's just a generic contract and it's non-negotiable. As subsequent jobs, I did. I got lawyers to look at contracts.
Yeah, same thing with me. When I got my very first like big girl contract, like your big attending contract, I actually didn't even know how to evaluate it because a lot of this stuff like base RVUs like really made no sense to me because they don't teach us any of this, right? They just teach us to go see patients. So I didn't have a lawyer look at it. What I did do is I had my dad look at it. He's really good at reading contracts, but he's not a lawyer. He doesn't know anything about medicine. So I think all he was doing was making sure that there wasn't like any big red flags. A lot of us just don't think about these things. According to Seek, they've stated that about 90% of physicians don't have their first contract reviewed by a lawyer, and many do regret it later. And that number, I think, is accurate because even within my own friend group who are physicians, I don't think anyone had a lawyer review their very first contract.
The people that I know, they didn't have lawyers to look at their contracts. And same, they do regret it later. Because later you realize that even just the small things can make a difference. I mean, there are a lot of things, and we can talk about some of the components, but there are a lot of things, even little things that you can negotiate for.
Anytime something affects your income, autonomy, and long term career, that's definitely something you should be paying attention to. But a lot of physicians don't even know where to start. Like, where do I find an employment lawyer who specializes in physicians contracts? And we can talk about that as well because I think you and I have both used Resolve and gotten good responses with that. So I'll link them in the caption. But there are pretty good employment lawyers also out there that expertise in physician contracts. So, what are some of the things that we need to watch out for when we're looking at contracts? One, you have to look at what your compensation structure is. Is it just base pay? Is it RVU? What's guaranteed? So your base is what's going to be guaranteed. Some contracts have a base where you'll make X amount of money at base, but if you exceed the amount of RVUs that they specify, then you get paid extra. Um, so what does that mean? RVUs is essentially how much a physician can bill per visit, per procedure. It varies among specialties.
It's based on also location, so geographic location.
You also have to look at productivity bonuses. So that's where you get either X amount of money flat rate or it's an RVU based productivity bonus. So you have to look at how that's calculated. Does it include the whole department or just you individually? Is it how much the company is able to collect or just based on how much you're billing? So there's various things to look at. But I think the main thing is to differentiate what the base pay is and what extra you can make with RVUs. If you're in, I think, and you can chime in, Shala, I think if you're in a position where it's strictly RVU based pay and you're employed under a corporation or a healthcare system, I think that can get very, very tricky because there's so much pressure to produce, and that will burn you out. And I think there's a lot of private practices that run on RVU based pay alone, and people run into trouble because of that.
I agree. I mean, there are some practices, they start you, for example, year one, they start you with a base and an RVU based pay. And then year two or year three, and you have to negotiate that. They can change, they'll change the base to be either lower or no base, then they move it to an RVU based pay. So by that time, the assumption is that you build your practice, you have the patient load, you can switch from a guaranteed base to an RVU based pay. But again, you have to talk to people around and see, do they like it? Were they able to get more pay over a year or over whatever years, or their pay actually was less? So there's a lot to consider in that RVU based pay.
Another thing, in addition to your base pay, is call pay. Are you getting paid extra for call, or is that something that is just assumed that you take? Now, I'll be very honest, when you're working W-2 jobs, especially in hospital systems, it's just assumed that you'll take call. Most people don't get compensated for their call. And I think that's crap, honestly, because I am someone who needs to sleep. And so if I'm giving up on sleep and I am getting woken up several times in the middle of the night, it almost to me sounds like they're saying that your sleep does not have any worth per se. Like you're just expected to take call. And then you do that for where I used to work, you were on call for like a week at a time, right? And then you'd work that weekend. So what would happen is you work from 9 to 5 and then you're on call after 5 p.m. every day, and then you work a weekend. That's how a call works. So by the time you're done with your 7 days, you're like terribly encephalopathic, even as an attending.
And no overtime for that. So it's all
No
part of your
overtime.
salary. It's not like
Exactly.
APPs
All
where
just a base
you
pay.
yeah, it's not like APPs where they get overtime. So no overtime for that. So you just have to like really factor all of that into the salary that you're receiving. Is it really 40 hours per week or it's much more than that?
Exactly. And if you factor in at one point, my husband, who's more business minded, he has his MBA, with factoring in the hours I was working to my salary, and he was like, "Hey, do you know you're making like X amount per hour?" And I'm like, "Don't tell me this."
There was a day that I literally was like from 7:30 to 9:19 p.m. I was on the laptop, and when I calculated, it was like really like dollars, for per hour. Yeah. And there are some jobs that are hourly.
Yeah.
So
There are jobs that are hourly, but also if you're going to sign up for a job that's an hourly job, really inquire how much the expectation is for you to work. Like, are they looking for 20 hours per week? Are they looking for 40 hours per week? Um, because if the expectation is you're going to get paid by the hour when you're like working and seeing patients, but they're still expecting you to take call or like do like a weekend without additional pay, I think that's not realistic either.
what is expected during that hour? How many patients are expected during that hour? So
Hmm.
that's important because if you are expected to see more patients during that hour, then you have to spend more time on documentation and other things on your own time.
Hmm.
So that's not going to be worth it either.
One of the red flag things that I think people fall into is productivity thresholds. Like you have to see a certain amount of people and you have to bill a certain amount, but you also don't want to be set in a situation where you're struggling to keep up. And instead of supporting you, your system's penalizing you for not billing enough?
Yeah.
And then next, you also want to look at what the expectation is for your schedule. So, for instance, how many clinic days are you supposed to be doing? And when you're doing clinic days, are you also doing inpatient work or is it just clinic? Um, how much admin time do you get? A lot of clinic only jobs. And even when you have clinic time, they'll give you like half a day out of the week for like catch up stuff. So, you want to be clear on what your clinic days are, what your inpatient days are. Is there ever a time you're doing both? How much admin time do you get? And what weekends look like? The other thing, just going back to the call, is a lot of outpatient only jobs sometimes still have call, even though you're not in a hospital, because patients need after hour care, right? They have questions, they want refills. So definitely ask, okay, after my clinic day, what happens when a patient calls um, at 6 p.m. for a refill, or they call on a weekend for a refill? Who takes care of that kind of stuff? Because I didn't ask those questions, and then I realized that even as an attending, that was part of my job.
No, that's important because you don't want to later get surprised that they say, "Oh yeah, you needed to take call after hours, and you didn't know before." Also, weekends. Same with the weekends, as you said.
Yeah, and how many weekends? Like, are you going to work one weekend a month? Are you going to work 2 weekends? Are you working like some jobs will say, oh, 10 weekends in a year? How is that dispersed? Holidays is another one. How are holidays split up? Is there any additional pay for holidays? Probably won't be, but these are the things that you also want to ask. Even if you're in an academic setting where I was and we had trainees with us, attendings were still responsible for a lot of after hour calls, including medication refills and patient questions. So those are all things that you do want to ask. You don't want to just assume.
Right. And you want to ask how much control you have over that schedule. If you need to change a day or take a day off, do you have to find alternative or there's a structure for it? So you want to ask that. And then if there are any caps on patient volume, that's a really important one that you have to ask. Okay, because most of these organizations they want you to see more, and you don't know there's if there's no cap, you can have lots of patients that you're responsible for, and your name is on those records. So you really want to make sure that there is a cap.
I mean, I think a lot of clinics do have caps, but again, in certain specialties like primary care, we said there often isn't a lot of cap. They'll say it's up to the physician's discretion, but in my experience, it's never really up to the physician's discretion. Where I was, I'm not a primary care physician. There was a time where they said, okay, new patient, you'll get X amount of time, but they changed that on us too. Every once in a while, not even every once in a while, pretty frequently actually, you'll have the clinic manager say, hey, this patient just needs to be seen, can you accommodate them? Or this person showed up on the wrong day, can you see them? And of course you want to be nice and do it, but how are you going to do that if you already have a full schedule and then patients are already annoyed that you're running late, right? So those are all things that I think are worth asking. Another thing that I think definitely is worth asking is, can you fire a patient? Because there have been many situations, and I've talked to friends, they've also had similar experiences. I've had this experience as well, where a patient can act in a threatening manner or say something that's very threatening, even in a patient message, or they can yell at you in person. But a lot of these corporations and healthcare systems will not allow you to fire that patient. You still have to see that patient. I had a situation where a patient was being incredibly rude over Epic My Chart, which is in the chart, by the way, people could see it. Um, and they still made me see the patient, but what they did was give me like an MA chaperone to go. Like, what was she going to do? You know what I mean? And again, not to, we've talked about this as women in medicine in our Women in Medicine series, but there's obviously already a gender bias. The man patient's already going to feel like he can act a certain way around you. On top of that, I'm a very small person, and you think that they have your back. You're still liable to see them.
That's crazy because we had a similar situation in the hospital when I was doing negotiations in residency, and so I mean, we didn't know exactly what was going on, but apparently, when we were covering the clinic, we found this from the news. So we opened up the news. One of my co-residents, they're like, "Have you seen the news?" And I'm like, "No." So we see it on the news that there's a shooter in the hospital. Okay, and this, so the hospital administrators, nobody even contacted us. So we found
They
it
were
from the
too busy
news.
going home themselves, is what was happening. they
Yeah.
said, they said, "Screw the doctors. We need to
Yes.
get out of here."
Exactly. And it's funny because my attending was like, no, 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 it's okay. Everything is fine. Just come and look at this MRI, you know. And so then we found out later, and of course, we had to leave the hospital, and then all of a sudden, I see everybody's running out, you know, so we had to like evacuate from the clinic, but the hospital people, they had to shelter. So then later, we found out that, and they told us, take your white coats off. Okay, so I was like, What? Like, why would we take our white coats off?" They said, "Name badge and white coats off." So then we found out that it was a patient that was pissed and basically threatened the doctor and said, "I'm going to shoot you," or "I'm going to come back and shoot you," or something like that. So at least they took it seriously. But the problem is they didn't let anybody know. And so we heard it from the news at first, that situation like that's happening. It's sad that these days, like these are real stories, It's really sad.
But in the bigger picture, we are the face of this failing healthcare system. And patients feel like we're the ones eating all their money. And so they have to take their aggression out on somebody. And this is where we are, unfortunately.
Yeah, it's
But
really unfortunate.
it's happening more and more frequently. So again, that was our long way of saying make sure you talk to your clinic about how they deal with disruptive patients, and whether you can control firing your own patients. Next is non-competes. Non-competes are very important to look at. They basically will restrict where you can practice once you have left that practice. It can be a geographic radius, but it doesn't have to be. Some places will specify a city, some will specify the state, some will specify the town. It can look very different depending on the contract, but they still are used quite a bit. I think they're crap too, but you want to make sure that, well, first of all, I think any place that gives you a non-compete is a red flag. That's just my personal opinion. But you want to make sure you are very clear on the distance that your non-compete applies in and the duration. Some of these non-competes will go on for years, which means once you've left that practice, you have to take your family and move, which I don't think is fair, because what do you mean? Like what other job does that? So
Right.
that's something to look into. And Shala, what California was working on restricting non-competes, or are they still doing non-competes?
I don't think they're enforceable in California, but what are they gonna do? They're gonna sue you. So I think it's more kind of fear mongering. It's a red flag for sure. But the first thing I would do, remove the non-compete altogether. Okay. And if they argue with you, then you can decrease the duration and the radius. But no, I would remove it. I would just remove it all
Yeah,
altogether.
I think if they refuse to remove it, I would move on. I don't think that's the right place for you, because obviously they're not respecting your physician autonomy.
But you really have to kind of plan ahead and make sure, just in case things change, right? A job can change, leadership can change, for example. A lot of things in a job can change, that you really want to make sure that you are covered in just in case.
Exactly. And that also leads me to like your exit. What does your exit and your termination clauses look like? One thing you want to pay attention to is how much notice do you have to give when you leave? Um, some academic jobs will say 90 days, some will say 120 days, some will say 6 months. I've seen 6 months. Like that's, I think, a little outrageous. The majority of jobs, and what I think is fair, is like 30 days. I think 30 days makes sense. It allows you to transition patients, but you want to be very clear because, like Shala said, stuff happens. You might not intend to leave the job, but you might have an emergency. You might have a family situation come up. Your spouse found a job elsewhere and you might need to move. You don't want to be handcuffed to your job for an extended duration of time, because that's not going to be helpful at all in the situation and will just be very stressful.
I would say no more than 60 days for sure.
No more. And then termination. What can they fire you for? And I think, definitely have this laid out, but in my experience, if a company wants to get rid of you, they will find a way to do it. But you want to be very clear on what they say in terms of the contracts. So how much notice do they need to give you if they're terminating you? Because you don't want to show up to work and be like, okay, yeah, that's it, because that happens to physicians as well. And what counts as a cause for termination? And is there a clause for any kind of retaliation? You want to look into that as well, because I have heard of physicians getting terminated because they have spoken up or shown some kind of like disruptive behavior or whatever they will label you as. And so, what counts as a cause for termination? Just be very, very leery of that. And if you do leave early or if you're terminated, what happens to the bonus that you worked so hard to obtain during that year? Does that just go away? So those are all things that you need to look at. And then also, if you end up leaving before your contract ends, or if they end up like terminating you, do you have to return any of the sign-on bonus if they gave you any sign-on bonus? And those are the things I think to look out for when it comes to termination clauses.
And so if tail coverage is covered,
Oh,
that's
tail
another
coverage as
area.
well. Yeah. Yeah. And I think a lot of physicians, myself included, did not really realize how malpractice insurance works. Now that I have my own malpractice insurance, now I know how it works. But tail coverage essentially is coverage for anything that can be brought up against you after you've left that job. A lot of jobs will do occurrence, which means while something comes up while you're still at the job, they'll cover it. But if anything comes up after you leave, it's like you're out of luck. So you need to get tail insurance for those jobs. So who pays it when you leave? And tail insurance, correct me if I'm wrong, it's for an X amount of time. It's not for perpetuity. I think you have to pay for it for an X amount of time, and sometimes you have to renew it. But in this case, who pays for it after you leave? If you leave in a patient that you were seeing in that practice ends up suing, um, who kind of manages that? And so tail insurance can be very expensive, and that's one thing to definitely negotiate. Make sure you know how long they'll cover it for as well.
Right. And you want to make sure that, you want to research that in your state, how long do the patients have to sue? So that also changes from state to state. So when you just in case if you have to get tail coverage, you want to know in advance how many years you need it for and how much you're going to pay for it. And you definitely need to factor that into the salary.
Exactly, because it can get expensive. I've heard anything from like $20,000 to 50 to even higher. Um, so definitely factor that in. And then, of course, benefits. Do they provide malpractice insurance? Most likely they will if it's a W-2 job. Your health insurance. Do they have any matching for 401ks? Disability insurance. Is there disability insurance that they provide? Any short-term or long-term? CME and licensing fees, do they pay that back to you? Is there any certain amount that is reimbursable? Conferences, like what is the money that you get to go to conferences? How many days do you get in terms of conference days? Those are all some things to ask for. We briefly mentioned a sign-on bonus when we were talking about termination, but some jobs will do a sign-on bonus and a relocation bonus. That is something I always think people should ask. I asked for it even though I was within the same city, but they still gave me a little bit of a relocation and sign-on bonus, which was nice. But if you don't ask, you will not receive. But when you do get those bonuses, make sure you're clear on how long you have to stay in that job before you are expected to pay that back.
And some pay, for example, a mortgage, a payment, like down payment for a mortgage. So you also want to ask, if you leave before a certain date, do you have to return that? And a lot of these jobs, they want to handcuff you to stay for a longer term. So be careful if you really kind of take the mortgage payment or things like that, because you have to make sure that it's the right fit for you.
So another thing that I think we need to be very mindful of when we sign these contracts is how much paid time off are you getting? Like what is your PTO time like? What is your sick leave time like? And also, when you're having this reviewed by an employment lawyer, you also want them to see if that's normal. Some places will really, really be stingy with how much paid time off they give you, how much sick time they give you. Some are just not very realistic. Um, and also, parental leave. Parental leave tends to be not uniform across all the health systems. Some people will give you some paid time off, most won't. I will say this, especially if you're pregnant and you're trying to take maternity leave. A lot of places will have you bundle up your unused vacation time and your sick time to then give you that as maternal leave, which I also think is crap because you're going to need that time when you have the baby too. And the baby event, kids get sick. So if you take up all your vacation and sick days beforehand, you're kind of screwing yourself, I think, a little later. But that seems to be the standard. Um, but I also know certain health systems won't give you even that if you've been there for less than a year. So they want you to be there for a year or more before they give you their standard parental leave, maternity leave. I mean, those types of things, I don't think you think about when you first start, especially if you don't have a family. But if you're considering starting a family, that's also something to think about. I'll also throw fertility benefits in there, because a lot of people, again, don't think about that till it comes time for it and you need to do IVF or whatever have you. Some health systems will pay for it as long as it's done within the health system. But again, that's not uniform across the board.
If they give you a stipend for your leave, then you want to make sure to know how long you're going to have to stay without returning that stipend back. And then the other thing I wanted to say is there are some kind of partnership models that there is no PTO or sick time. You can take a vacation, but it's not paid. Okay, so you want to factor that in your salary or your pay to make sure that because you're taking that time off and you're not getting paid anything, so the pay should be higher in those situations.
Exactly. Some of these models that are RVU based are what we call eat what you kill, I think. So if you're not producing, you're not making money back. And I think that's going to be difficult, especially if you're someone who wants to take X amount of time off or needs to take time off for whatever reason. The last thing you want to do is some unexpected emergency and have no way of getting paid for that time. Like I said, some companies will offer short-term disability policies, but it's not uniform across health systems.
Right. So you want to take a look at all of this.
People that are doing ownership or partnership tracks, often this is in private practice. Make sure you get everything in writing. That's the first thing, and really ask the questions of what is the path to getting equity or partnership within this organization. What is the timeline, and what are the expectations? Is there buy-in amount? Like, do I have to put in money up front, or is it based on performance metrics, or is it both? Like, do I have to buy in and then also bill X amount to continue down this pathway? But again, get everything in writing. You have to have everything in writing.
In the partnership models, make sure you ask about health insurance, how health insurance is covered. If you have to pay for a high amount, that's also factored in into the bigger picture of your salary or what you're getting paid. You have to really look at the details.
Right, because when you're entering a partnership, you're not just looking at you as an individual. Now you're paying for everyone in that partnership. So things are going to be different. Like, for example, and this is just very limited knowledge. I'm not part of any partnership, but what I've heard is in certain situations, because I do have friends that are in partnership tracks, your health insurance costs might go up because now everyone in that partnership is also being insured under the same umbrella. Some of these people might be older, they might have chronic health conditions. And so that cost might go up. The other thing is, I also have friends who have had to take out loans to buy into partnerships because sometimes you have to put like $100,000, $200,000 upfront to show that you're committed to the partnership, which to me is too much commitment personally. But if it's for you, that's totally fine because at the end of the day, partners can make more money. But if you're going to take more out of the pot, they also expect that you put more in.
Right. Also understand the profit sharing and how that's distributed among the partners. Is there different levels? Are there, are you a full partner? What kind of partnership tract you're entering? So a lot of details to ask.
And I think after you reviewed your contract, definitely get a few people to look at your contract. But the big thing is have it reviewed by a healthcare attorney, not just like any general run of the mill lawyer. Talk to a healthcare attorney because they'll tell you if you're being treated fairly, if the salary is fair, if the RVU expectation is fair, what is standard, what is expected. We don't know that. They know that because they're on the business side of things. I'll call the podcast had a contract attorney on, and he said that where physicians are like some of the dumbest people when it comes to contracts. And I fully agree with that. I think we just kind of blindly sign up for stuff without realizing what exactly we're signing up for. And I'm saying that as someone who also did that. So definitely get a healthcare attorney to look over things.
I mean, this is what we said. The new grads, unfortunately, and we were new grads too, and we did the same thing. It's just because you compare the salary to what you were getting paid. I mean, I was going through my records and I was looking at my pay during my fellowship. I was laughing. I was like, how did I even survive on this? And how did I even not stress out about this, something like this, about this amount? When you see this significant increase in compensation, you're so happy. You're like, oh my gosh, I don't want to negotiate for anything. I don't, this is enough for me. But then soon after, you realize that your expenses significantly increase, your student loan repayments start based on your compensation, which can go from a couple $100s to a few $1,000s a month. So, and then you have childcare expenses and you have mortgage and you have, you want to travel, now you're attending. I mean, it's just lots of expenses that you really have to negotiate for your value because you're very valuable after you graduate. Know your value and negotiate for it. Any job that you are evaluating, any offer that you're evaluating, make sure you talk to as many people as possible from that job. And I would say even kind of have similar questions, asking each one of them to compare the answers. Then you'll know, if they're not having the same answers, if they're, then you'll know they're not being honest with you. And some of the questions that you can ask, like, tell me how your day to day or week to week looks like. Or, do you feel that you have a supportive leader or supportive boss? Do you do work beyond your scheduled hours, for example? Or how manageable is your patient load? Do you have caps? Do you have, what is your caseload? And then other things like, do you have support? Your admins, right? Do you get enough support from your admins and staff and supportive staff or ancillary staff? Questions about the culture. You want to make sure that you ask, do you feel that you have kind of autonomy? Does someone micromanage you? You need to ask all these questions. I'm sure you have more questions to add to this, Santoshi.
You nailed everything on the head, all of that. Also ask what their attrition rate is. Like,
Oh
have
yeah.
a lot of people left recently? That is something because people don't leave when they're happy, right? So if you're in a place that has very high turnover and you're only seeing new people, but not people who've been there for an extended period of time, I think that's definitely a red flag.
And you want to ask that person how long you've been here. That's important to know because if they're there for just a few months, they may not have the whole picture. So you definitely want to ask multiple people same questions, compare their answers, and if you feel that their answers are not matching, it's not a good fit. That means there is something going on in there.
So a few things, definitely get a healthcare attorney to review things. Resolve.com, I think Shala and I have both used and have had good experiences with. Definitely talk to people as well because the contract is part of it, but the bigger part is the culture you're going to be entering. Even if you have an amazing contract, if the workplace is toxic, it's just not going to be worth it.
All right. Thanks for tuning in to Be Empowered, the podcast. If you enjoyed this conversation, don't forget to subscribe, rate, and leave a review. Share this with someone who needs to hear this. Stay strong, stay empowered, and we'll see you next time.
Thank you.
Thank you. Bye.